Okay, everybody back?
And you only working 11 and 7.
Yes, ma'am.
Those
Okay.
are just your pickup days.
Yes.
Thinking
So
caps.
you're doing
Come on.
11 Friday, Saturday, and Sunday.
Mhm.
Every Friday, Saturday,
All right,
Sunday.
I hear you.
Yes.
Oh, Sophia, let me mute you.
Okay.
Okay. Okay. All right, I'm ready to rock and roll. So I'm recording and let's do it. Okay. Okay. All right. Hi, Mr. Sanj. I got some more people that came on. Good to see you. All righty. Do me a favor too. Just take a few minutes and put your name and who your professor is. If you're visiting, if you're a visitor today, so I have your name, please. Okay. They are keeping attendance on reviews. All right. There is a strong, hey, I give you all a lot of credit for attending a review. There is a strong evidence in research that shows that students that attend reviews do much better on their exams. So I just wanted to commend you all for taking a Friday afternoon and spending it with me. Okay. Okay. All right. As you do that, I'm going to share my screen and I'm going to continue. Okay.
I like that.
All righty. We're moving right along. And so now we're going to discuss chapter 13. And we know chapter 13 is the preterm and post-term new.
I don't care what I eat goes there. But he
Okay, guys, I need you to mute yourselves. Okay, okay, all right. Okay, so this is what you would see if you had a preemie baby. If moms are not doing what they're supposed to do during their prenatal time, such as like not smoking and they smoked, you can have a preemie baby, and this is where the baby would end up when they're born. They need, because why? They have, everything is so immature in these babies, and so they need help to survive. Okay, so this is an incubator where there's the temperature is a constant temperature for them, constant oxygen delivering to them, and they're on a lot of different monitors and being well watched by the NICU nurses. This is a typical NICU. Okay. So when we do gestational age on a baby, we're actually looking at to see how what. Let me get rid of this. To see how they are, you know, how old they are. So that's called gestational age. And so we talked about this already, like preterm infants is less than 37 weeks. And then you got early term infants between 37 weeks and 38 and what? And 38 and 6, that's early term. And then you got full term between 39 and 40 weeks. And yeah, see that? And I kind of laid it out like that for you, just to that you have an idea. If you know the term comes up, like what is a late term infant? That's between 41 weeks and 41 and 6 days. We call it like 6/7. We write it as a fraction. And then post term would be what? Anything, any baby, what? Between 42 weeks and beyond.
Yeah.
Yeah, that's where I tell you, I'm gonna be honest with you. That's where I get nervous about these babies here, these post-term babies, because everything gets everything gets old, everything gets used up inside. You know, the placenta gets old, it gets calcified, and I mean I have lost babies. I've seen that happen where my baby died in utero. I had to take care of this lady, and it's not nice. I mean, you know, we try to get this lady in before she got to be 43 weeks. It was just too old. Baby didn't get the oxygen it needed. Okay, so here's your little brain teaser. So which classification will the nurse assign on an infant born after 42 weeks?
Post time?
Post-term, exactly. So that's an example of a question that could be asked. All right. This slide is not the best slide. I'll tell you some of my colors here, but anyway, you can read it. Let's talk about RDS, which respiratory distress syndrome. All right, so I also refer to a lot of times as hyaline membrane disease. That's another term. And what it is, all you have to write down is immature lungs that leads to impaired or decreased gas exchange. All right, so here you are, Patrick. Surfactant is a fatty protein that is high in lecithin, and its presence is necessary for the lungs to absorb oxygen. We already talked about this, so I would just make note to it. Okay, guys? All right. So here's my brain teaser. So which complication will the nurse assess for in a preterm infant who is deficient in surfactant? So it's just another way of asking the same kind of question, but I'm reversing it. So which one would you pick?
Respiratory distress.
Respiratory distress, exactly. So again, go back to the question. So which complication will the nurse assess for a preterm infant? So the baby's preterm who is what? Deficient or who doesn't have enough in surfactant and would be respiratory distress. Absolutely. Okay. Can you see how that question can be turned around? How it can be asked in a couple of different ways?
No. Can you come
No?
again, man? Yeah. Can
Can't
you
see
come
that?
again? Because I lost connection when you were doing that.
Oh, okay. All right. So
Because he's driving.
No, I'm not driving.
oh, you
I'm
better.
not driving. I lost I had a call that came in and cut off my connection. So I'm
That's
not
okay.
driving.
That's okay.
That's
All right,
okay,
so-
Chris.
All right, so remember this slide we talked about here. We talked about respiratory distress syndrome. And what did we say? We said that, again, the lungs are not getting the oxygen it needs, right? There's an impaired gas exchange. And remember, we have to have surfactant in order that we can breathe adequately, correct? Okay.
Mm-hmm.
All right. So then here's a question about it. So here you can take, so which complication will the nurse assess for in a preterm infant who is deficient in surfactant?
D.
D, absolutely, respiratory distress. Okay, good. All right, remember that, guys. All right, so how do you take care of this baby with RDS? Well, you're gonna monitor vital signs, right?
Science, yeah.
Yeah. Taking the pulse.
Yeah, I'm going to, maybe, he probably gets some oxygen, right? But I'm gonna monitor his pulse oximetry, right?
Right.
All right.
Fluid.
But I don't want to give him too much oxygen. We talked about that already. I'm gonna give him some IV fluids. Remember that little picture I showed you? The baby had an IV.
How do you
Yeah.
know how much oxygen the kid needs?
Oh, Patrick, you had to put a pulse oximeter on them. And you put it on a baby, you put it on their foot. And
Okay.
it's the same reason why you put a pulse oximeter on an adult, is I want to see how much oxygen is what in his blood. So I put that on there to see what level it is. Now, if I have a level of say 92 or greater, then I know I don't need to give that baby any higher oxygen. I've got it where I need to be, right? Because 92% or higher, right, is enough.
Yep.
So, but if I had a reading that was below, then I would know I would have to what? Titrate to effect. Okay, titrate to the recommended amount. Okay, so everybody got that?
Yep.
Like little by little.
All right, little by little, we'll get there. All right, so here is what we talked about earlier about bronchopulmonary dysplasia. So here's a slide on it. So it's what it is. It's a toxic response of the lungs to oxygen therapy. It's too much oxygen. I think someone asked me that before. So too much. I don't want to give too much, because when I give too much, I got oxygen toxicity. I can cause problems such as this. And often it's a result of prolonged dependence too on supplemental oxygen and ventilators. And I'm going to tell you, it has long-term complications, and one of them is the eyes. That's why sometimes you see children who have been a preemie, they have the little eyeglasses really early in life. That's because they got too much oxygen. Years ago, we did that. We gave oxygen like crazy. But we have, over the years, there's been a lot of research on that and shown that we can give too much. Okay, so neonatal hypoxia, again, what is that? Is inadequate oxygenation. That's all it is at the cellular level. That's all it is. How am I gonna record this, or how am I gonna know? Is using a pulse oximeter.
Pulse oximeter. Okay.
That's all. And there it is. Saturation levels 92% or above
Normal.
is normal. All right. And so, you know, if I have a severely anemic infant, I may have, you know, more severe hypoxia. It's all according to my baby. So according to how early they are. Imagine that little guy, if he was born at 22 weeks. He don't have very much. He don't even have what, surfactant circulating. He really is going to need to be on what, IV. He'll be on oxygen, and so he'll have to be very much watched, right? Okay, so
Yeah.
here's a pre-teaser. All right, I know you can get this. The nurse is assessing the pulse oximetry of preterm infants. All right, which of the
D.
following indicates a normal reading?
D.
Is everybody in agreement?
Yes, D.
Yes. Okay, good. I think we killed that one. All right.
Chris,
Yeah.
correct.
I think we killed it.
We killed it.
I'm gonna need oxygen. All right. We talked about this already, I think, but here it is. Cold stress. You will see these again. All right. Is this a really great all that apply question?
Yep.
You better believe it. So signs and symptoms of cold stress. You got decreased skin temperature. What happens to the respiratory rate?
Yeah.
It goes up.
Yeah.
Write
Yeah.
that down. Increased tachypnea. It goes up. Okay. What happens to his heart rate?
Go up.
It goes
Go up.
down.
Down.
Bradycardia.
Bradycardia. Yep.
Okay. What happens to the skin?
Modeling of the
Right.
skin. Or
Okay. Right. And am I tired? Am I lethargic? I
Yeah.
am.
Yes.
Yes, I am. Why? Because I'm in cold stress. You made me cold. This is
Mhm.
what can I, symptom? It happens to babies when you don't have you're not watching the thermoregulation, making sure they're not in a draft, making sure that when they're born, they're dried off immediately and put in with a nice warm blanket. What else should I put on him? His little hat, right?
Yeah.
Okay. You don't want to cold stress a baby. When you cold stress a baby, this is what happens. His skin temperature, he's cold. It's going to go down.
Mhm.
So if I'm cold, my respiratory rate is going to go what? Up, because I'm cold and I'm trying to keep warm. Okay. And I'm working so hard that I may not even breathe. That's not good for baby. And then because I'm working so hard to breathe, what? My heart is now taking a hit. And so my heart rate goes down. And because of all this, I don't get enough blood circulation through my skin. It kind of looks blotchy, and that's modeling.
Modeling.
And then, am I tired? Yeah,
Yep.
I've been working hard trying to keep warm because the nurse is not keeping me warm. Okay, y'all got it now?
Yep.
Okay, good.
Yeah.
All right, I'm gonna move on. So here, which are the assessment findings will the nurse associate with cold stress in a preterm infant? You tell me.
A,
Mhm.
C, C, D,
D.
ACD.
That's right. Very good. Good. Okay, we got that. All right. How about we talk about jaundice? Now, remember, these babies, I mean, they have a liver, but the liver is immature. So what happens is that you get what? You get a lot of destruction. The let's see, let me put it this way. The liver is unable to clear the blood of bile pigments, which can result from the normal postnatal destruction of RBCs. So what happens is that you have the normal, destruction RBCs are going, but because my liver is not, mature yet, that I can't keep up with all this extra bile. And so the bilirubin goes up. So the higher the serum bilirubin, then the higher the jaundice and the greater risk for neurological damage. So that's why we watch these babies very closely. So there's two types of jaundice. You have the pathological jaundice, which is in the first 24 hours. Okay. Now, even when I say pathological, don't you like go, ooh, that's not good, right? It's not good. No. And so that you would have to watch that baby very closely. Maybe mom was Rh negative and now we have an Rh positive baby. They had mixture. Maybe he has erythroblastosis fetalis. And so he has more of what we call pathological jaundice. But then you have the other jaundice, which is called physiological jaundice. And that happens about the third day, he has, his little liver is not keeping up with the amount of bile salts. And so basically the bilirubin's going up and he gets a little yellow. You take your finger and you press against his little nose. And when you release it, you see the yellow. Okay. Well, we can take care of this jaundice before it gets to what we call kernicterus, which can cause brain damage. Okay. So we take care of this baby through phototherapy. All right. And let me show you what that, see phototherapy, that's a treatment of jaundice. Okay. Now, what's my goals of treating jaundice?
Ma'am, I think I've seen an instance where an infant is vitamin D. Leaves early in the morning. They take the baby out to the balcony to get some vitamin D. And
yeah, I mean, like if you live like in the South.
In Florida, yeah, we got enough.
Yeah, if you live in Florida, you can just take the baby out. Yeah. If you have physiological jaundice, yeah, we tell them take the baby out and let the sunshine, the ultraviolet light effects from the sun hit the baby. And that normally does it very well. Plus the baby's breastfeeding and taking in fluids, so we can get rid of that. But if we don't, and we have baby has a real high bilirubin level, then we have to do the phototherapy.
Phototherapy, gotcha.
Yeah. And because you want to prevent kernicterus. You want to prevent that by preventing the rising of bilirubin. Yeah, because what happens is that the brain gets involved and it can cause brain damage. So we have to be very, very careful with these babies. And so what's our nursing goals going to be? Well, you're going to observe the skin color, the sclera, and mucous membranes. Okay, always for the signs of jaundice. And then we're going to report the progression of jaundice from the face. It goes from the face to the abdomen and the feet. So we're going to monitor and report any abnormal lab results. And of course, the response to phototherapy. Now, this is the picture of the phototherapy that's used. And you can see this baby is probably a preemie and in the phototherapy getting all this ultraviolet. Okay. And baby skin is exposed. And so what you want to do is just have maybe a little diaper on, just so that, when he wets or has a bowel movement, it goes on to the little diaper, and then all the skin is to the ultraviolet. Okay. And then the main thing about too is that he has eye patches on. So his eyes are protected, because just like you wouldn't go out in the sun and look directly up in the sun, right? Because it hurts your eyes, correct? So this little baby is underneath these lights, so his eyes had to be protected. Okay. That's always a good question. So on our preemie babies, they have some special needs. Okay, so what we're gonna do, we always worry about respirations, right? Always, guys, is preemie babies, is return babies, we worry about breathing. We want to maintain their body heat. Preemie babies are more prone to being what? Cold stress, because they have a hard time. First of all, they don't have a lot of subcutaneous fat. Okay. And they don't have the brown fat. They don't have the brown fat that other babies have when you're born as a preemie. So they can't maintain their own little body heat. We want to conserve energy because when you go in and take care of these babies, what you have to do is do cluster care. And cluster care is getting everything you want to do for this baby and do it in one time.
One time. Yep.
Yeah. Because even touching a preemie baby can stress them out. Okay. So we don't want to do that because otherwise they lose a lot of energy and they have to use what glucose they have, and then they get hypoglycemic, and that goes into respiratory distress. So I don't want to do that. You understand? See the connection? Now, I always want to prevent infection because a preemie baby doesn't have the immunity. So they are wide open for an infection. So you have to have utmost care, and you have to make sure that anybody that comes near this baby or touches this baby, hands are washed. Okay?
Hand wash. Yep.
Yes, hand washing. And for a preemie, you always want to have proper nutrition and hydration and good skin care. Their skin is so fragile, just like I can say, like a geriatric patient. Their skin is so fragile. And then you always want to observe them, and you want to record any observations. And when you're recording your observation, you should see a progression of getting better, or doing better. His pulse oximetry levels are better, and maybe he's moving a little bit. So all those you observe, and then support and encourage the parents. The parents and the family, they take it's a lot of stress when you have a preemie baby, and they're very much concerned about the financial burden too, because NICU, guys, is not cheap, as you could probably tell. All right, so the best way for a pretermer to get fed, because a lot of times these real preemies, they don't have the reflex we call of sucking. So they can't even get fed the right way. They may have to have a gavage feeding. And you can put,
Gavage.
you can put, write that down, gavage feeding. Write that down, everybody, because you'll see it again. You can have the breast milk through that, or you can put formula. The main thing is that, you want to make sure the baby gets, proper hydration and nutrition. Now, when you're giving the gavage feeding, main thing is you always want to, now write it down, aspirate first before you give the next feeding. Okay, so say baby ate at 12 o'clock, and now he's due again, say at 3 o'clock to eat. Okay, so before that 3 o'clock feeding, I'm going to take my syringe and I'm going to pull back a little bit and to see if I get any. Now, if I get undigested milk or some extra milk or coming back at me, that means that baby hasn't digested that. So I'm not going to give him more because that would be too much. So that's why we have to make sure before we give another feeding, we aspirate. Okay.
Gavage feeding, is that through your stomach?
If you notice in the book, they have like a little tube and it goes through the nose and into the stomach. And then
it's not gonna stop the baby breathing?
Yeah, it's a way to feed. And then what we do is you have this tube, right? And and we just kind of put a little I don't know, it's not tape, but it's a little attachment, and then we keep it in place, and then we hook it, and at the end there's an opening. So when we're ready to feed, we take our syringe with breast milk, and we're going to first, though, remember, we're going to aspirate. There's nothing there. and that baby has digested everything. And then we're going to pour in more breast milk. And then that's how we feed the babies. Because they don't have, Patrick, they don't have that reflex of sucking. So they can't eat that way, right? So we have to give them nutrition.
I was thinking about the respiration of the kid could be so low, so they might go to the stomach.
Yeah, it gets in there.
Okay.
Okay, so here you go. Here's your brain teaser. Now, Patrick, I'm going to let you answer this one, all right? I'm not picking on you. But which nursing action is most appropriate prior to starting a gavage feeding on a preterm infant?
The last one. That's too easy.
Oh, thank you. Patrick, you're getting good. You're learning.
That's good. Keep it up. Great job.
Thank you. Thank you, Chris. Thank you,
Great
Chris.
job. Great job.
I love when I get students that do that. Yeah, you're learning. That's right.
Yeah.
Okay, so now we already did pretermers. Okay, so you can understand that a pretermer has some special needs. Okay, now we're gonna tell you some problems associated with a post-term delivery. You know, it happens too. They're in there too long, so they can have what we call meconium aspiration syndrome. That means where they were in utero, they had their first bowel movement in utero, and now I'm delivering, and I kind of took my breath before you suction me out properly, and I'm aspirating on meconium. Those babies are sick, by the way. Really, really, really sick. So when you have a baby that's post-term and you have meconium stained fluid, when that baby's head pops out, I'm there with wall suctioning, and I'm going to suction the baby out. And I'm not going to stimulate this baby to breathe because I want to get more of that meconium out, because I do not want him to aspirate on the meconium. Because again, meconium aspiration syndrome, these babies end up in the NICU and they end up with an IV, and they're sick babies, real sick babies. They have poor nutritional status. They may have increased polycythemia, may have an increase in red blood cell count. They may be real red at birth. Difficult delivery. Yeah, because while I'm inside and I'm now at 42 weeks, I just was in there gaining weight. So I'm a big baby. So you may be delivering a 10-pound baby. So you can have a difficult delivery. That's not good for a baby either. Okay. You know, if you have shoulder dystocia related to increased size of the fetus, then, you know, you got to break my clavicle to get me out. All right. Yeah, not good. And sometimes they have different birth defects, and then they have these seizures that can happen. Not good. So what's your nursing care of your post-term newborn? Well, I'm going to watch for respiratory distress. And actually, don't we do that on our babies, all babies? Don't we worry about respirations? Yes. These big babies, though, can be hypoglycemia, especially if mommy is a diabetic. Now, could be a good question. And so you want to make sure that you're ready to test the blood sugar at birth. And he could be hyperbilirubinemia. That means that he's already producing, his bilirubin is already has already started to increase in before. And so now that my immature liver is really having a tough time. It's really hard. And then again, these babies too can be prone to cold stress. All right. So here's another question for you. There are two fontanelles right on the baby. You have the interior and you have the posterior. The interior is a larger diamond-shaped one, correct? Okay. So my question is, what does it mean when a nurse assesses an infant with a sunken fontanelle?
Dehydration.
Occupation.
Yes, good for you. Sunken fontanelle. Write that down. Wonderful. Yes, dehydration. Then what does it mean when a nurse assesses an infant with a bulging fontanelle?
Correction.
What does it mean when it's bulging?
Hematoma?
maybe some increased what, cerebral spinal fluid. I have some fluid over there. Is
Increased
that a good
pressure.
sign?
So, no,
No, no, that's not a good sign either. So either one of these are not good. Okay. All right. So we're gonna move right into chapter 14, and this was the newborn with the perinatal injury or congenital malformations. All right. So you have some classifications of birth defects. We went over these before, but you have like inborn errors in metabolism. That could be what?
what?
Inborn errors in metabolism. What falls underneath it? Underneath that one?
Disorder of the blood.
Like maybe
Uh,
maple syrup, maybe what, PKU?
yeah, yep,
Yeah.
PKU.
Let's go on here. I'll talk about these. Then you have, okay, here's a question. So you have active and efficient participation in prenatal care can significantly decrease the risk of congenital anomalies.
True.
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 Absolutely. Absolutely. Yeah, like the one we're going to talk about was like spina bifida and hydrocephalus. What
Mhm.
should mommy take during her preconception?
Folic acid.
Yes, very good. Absolutely. And here we are. These are the neural tube defects. So we're going to talk about. So hydrocephalus and spina bifida. Okay. Here's a little baby with hydrocephalus, and you can see these babies have what? A very large head. You can see their eyes. You can see how abnormal this is because what's in there is what? Cerebral spinal fluid, right? The ventricles are not draining. So there was a problem in the development of this baby. And so therefore now it's going to show up when this baby's born. And so these are your classic signs. Now, the one I really want you to write down is there is definitely increase in the size of the head. Yes. And so if the head is so heavy, it's big and it's heavy, and this is a baby, guys, I have to worry about him getting fed, but what am I going to do? Well, make sure that I stabilize the head right when I'm feeding the baby. Is that correct?
Yeah.
Yes, that's the main thing. So because the head is so heavy that you want to make sure that you stabilize the head. Okay. And of course, the scalp is very shiny like you saw in that picture, and the veins in the head are quite dilated. So here you go. Here's a little brain teaser. So which assessment finding will the nurse expect for an infant diagnosed with hydrocephalus?
Growing head. Two.
Two.
Large and rapidly growing head.
Yeah, 2. Now, 2 is correct. So write that down. And number 1, protruding tongue with a short, thick neck. That's Down syndrome, baby.
Yeah.
And then number 3 is an inward turning of the ankle and foot. That's a baby born with a club foot. And then number 4, a hairy patch in the lumbar sacral region. That's spina bifida occulta. So yes, so the question was asking me about hydrocephalus. So I knew that those babies have a large head, and it is a large and rapidly growing head, because what happens, that cerebral spinal fluid has nowhere to drain. And so therefore it's just staying in the head. It doesn't drain properly. So here are your symptoms of increasing intracranial pressure. And the biggest one that you're seeing is that bulging fontanelle that we talked about. You would see, so I did highlight it here, so write that down. Bulging fontanelle, you would see that in an infant with hydrocephalus related to increase in intracranial pressure. And here's my little picture where you can see the ventricles here. And you can see the enlargement. You can see where it needs to go. So here's your shunt. They have to put a shunt in. And what that shunt does, it drains. And this baby, this child, will have multiple surgeries because they will grow. But they can survive. They can do very well. and we teach the parents how to actually pump this shunt. And they do live very nice lives. Okay, the other one I was going to talk about is spina bifida. Okay, so you can see here on the first one, let's see here, the spinal cord, and you can see the spinal cord meninges, and here's your defect right here. So this is where you would see that little maybe tuft of hair, because you can't see too much. It's called spina bifida occulta. And this one here, you can see where you have a bulging here. The meninges are protruding. And this one is a defect in bony canal. You have the meninges protruding and the spinal cord is actually protruding. These are not good. Okay, you have to do surgery, of course. But the main thing is when a nurse comes across this, and we see this sometimes, and we see it in the delivery room, we want to protect these sacs. We don't want them to dry out. You never want an organ to dry out. So we're going to use sterile towel with sterile saline and cover this, protect it. And when you position the baby, you always position the baby to protect the sacs. All right. So again, we talked about this already. To prevent an open neural tube defect, mom takes folic acid. Wonderful thing. And that was the best research I participated in. And here's your nursing care of spina bifida. All right. So what I want to do is remember, prevent infection. Imagine that sac got infected. It probably would kill this baby. So you want to prevent infection or injury to the sac. Correct positioning. Always prevent the pressure on the sac. Prevent development of contractures. That's why they'll probably go into a place called habilitation, where they do a lot of good exercises for these children. Good skin care. They need adequate nutrition to keep going and for their bodies to keep producing. Accurate observation and charting. And the parents, guys, the parents need a lot of information. Now, these children with spina bifida, they have continued medical supervision because they don't have any control over urination nor excretion, elimination of feces. So they have a lot that goes on. And then they go through what we call habilitation, and that's a place that they can live, and they always look at the positive in the children. They want to make the children feel like normal as can be, and they do very well there. Okay. So upon delivery, this is what you do for a baby with spina bifida. The newborn is placed in an incubator, because he's going to lose a lot of body heat. And here you go. I want you to make sure that you know this. You have a moist, sterile dressing of saline or an antibiotic solution that can be ordered to prevent drying of the sac. So you always want to protect the sac, and it's moist. You hear me? It's moist.
Yep. Moist and sterile.
Yeah, because it has to be sterile, because I don't want a baby to get infection, right? And moist because and when an organ, guys, is outside the body, the air will dry it up very, very quickly. And so I don't want that to happen. So I'm going to put in moist sterile. It can be anything. Anytime that an organ comes out of your body, maybe you have a car accident or whatever, someone comes and you have protrusion of someone coming out of your body, you want to make sure you keep it alive. And that's how you keep it alive, is by putting a moist, sterile dressing. All right. So here's my little brain teaser. So the nurse is caring for an infant born with spina bifida myelomeningeal seal. That means that everything is sticking out, right? And so which intervention will the nurse implement to protect the sac?
2. Moist. 2.
2. Yes. Now, and the reason why I'm showing you, I want to show you these different answers here, because a lot of people can probably see one and say, oh, that's it. Apply a dry, sterile dressing. But they don't see the word dry. They just see apply sterile dressing. And then you say, oh, I remember her talking about that. But no, This little word here is very important because that is dry. We don't want it dry. We want it with a sterile cloth moistened with saline. We don't leave it open to air, allowed to dry, because we don't want that to dry out. And you don't cover petroleum gauze dressing. I just wanted to show you how sometimes your eyes, when you're looking at the answers to these questions, how you can jump right away. And I don't want you to do that. And sometimes people do that, and then they get it wrong. All right, so we're going to move into a baby with a cleft lip, and that's characterized by that fissure opening in the upper lip. Again, what happened during the embryonic development, it didn't close. And so maybe mom was taking drugs, maybe she was smoking, maybe, you know, a lot of things can happen during the embryonic development because you don't realize that you're even pregnant during the embryonic because it's so early. In some cases are hereditary. And it appears to be more often in boys than girls. And I just want to show you here a little picture. And this is a baby with a cleft lip. Now, these babies you have to worry about. Now, cleft lip and cleft palate are both two deformities that I have to worry about nutrition. Write that down. The nurse has to worry about nutrition with these babies. So what's my treatment? Well, gonna have surgery to repair it. And so usually by 3 months of age. And then, you know, whenever you do surgery like that, you have to have maybe elbow restraints to prevent the infant from scratching the lip because you want it to close properly. And so you want to make sure that the baby doesn't scratch it open because these chilioplasty, which is a surgical procedure, do very well. But this here has to heal properly in order to look nice. So there's less scar. So that's why you have to be really careful and make sure that they don't tear the lip apart. Now, you may probably have a special syringe or a bottle may be needed to assist in the feeding until the surgery has occurred. Okay. It's not easy. It's not easy for the parents. No. And sometimes they have to be fed by a medicine dropper until the wound is healed. So they're going to need parents are going to need a lot of support. Definitely. And here, this is always a good question. You cleanse the mouth by giving the infant small amounts of sterile water at the end of each feeding, because it can get a little bit messy. And two, you want to be able to cleanse the gums and everything inside the mouth, keep it nice and moist. Now, the cleft palate. It's just the failure of the hard palate to fuse during like the 7 to 12 week of gestation. Again, you know, that's a very important time. That's in the fetal development time, right? Going well, yeah. And so it doesn't close. And so it forms like cleft palate forms like a passageway between the nasal pharynx and the nose. So what happens, there's an increased risk of the respiratory tract and the middle ear. Okay. Do me a favor, write down that the cleft palate, they have problems with respiratory tract and infection in the middle ears. It's because that passageway between the nasal pharynx and the nose is not closed. So a lot of things can get into that area and they have a lot of middle ear infections. All right, we're gonna move right along here. So post-operative care, these children, you do not, no food through straws. You don't want these babies to suck. That's hard. And so you don't want don't ever offer a straw for that. Oral hygiene, again, we're gonna cleanse with clear water to rinse the mouth out. These children probably will have to go to have some speech therapy. Because they got to learn how to pronounce words correctly. Guess what, guys? You can't have these babies to cry. Crying should be avoided whenever possible. Is that hard?
Yes,
Oh,
it is.
yeah, it's really hard on children, on babies. So you don't want them to cry. And here it is, ear infections and tooth decay. That's why you want to rinse the mouth out and after the feedings, make sure that it's all clean, and ear infections, big time. All right. So my brain teaser, what condition is commonly associated with an infant with a cleft palate?
Infection of the ear,
Infection
middle,
of the ear, middle ear.
Yeah, good, you got it, right, let's go along. All righty. Okay, what should the nurse be concerned about when caring for an infant with a cleft lip or cleft palate?
nutrition,
Nutrition.
Nutrition.
You're listening. Very good. Very good. Okay, moving right into hip dysplasia. All right. So you know these from your book and from your lectures, you can see the difference in the gluteal folds, right? Correct? All right.
Yeah.
Yes. So here, that's called hip dysplasia. And what happens, you have various forms of degrees of deformity, such as subluxation or dislocation. Well, what happens is just that, let me go back here, you know, the head of the femur doesn't fit into the acembellum like it should. So what happens, you can even hear a click sometimes. And so your gluteal folds don't, what? They don't measure up. They're not the same. Are they the same? No. So that's how you could tell. And we do that actually in the delivery room, is that we hold the baby up to see how those gluteal folds are. Now, it's 7 times more common in girls. And you can really see this more as that baby starts to become like a little toddler and starts to walk. All right. So here is my brain teaser. So the nurse is assessing a newborn and she notices the gluteal fold to be higher on one side. What condition is she finding?
Hip dysplasia.
Yes, hip dysplasia. You got it. Okay. All right. So here you go. I think this one's for Chris. Chris, the nurse is assessing an infant with a tougher hair or a dimple on the sacrum. What is this nurse concerned about?
A spina bifida.
Okay, spina bifida occulta. Good. Okay. All right. So this is another slide I kind of put in here. It's just the nursing care. We already went over this. Oh, that's just I guess a copy of my other one. So I'm gonna go over. Let me see. We went over this already. How about we go into PKU? All right. So this, remember we talked about the inborn metabolism errors. And
Yep.
so this is one that's pretty popular. Everybody knows about PKU, right?
Yep.
What happens is that this baby's unable to digest the essential acid and it's called phenolphthalein. So what happens is phenolphthalein accumulates in the blood and it's found in the urine during the first week of life. Now, we tested by doing a little blood test. It's called the Guthrie test. And you have to wait at least 24 to 48 hours because the baby's got to get enough protein in his system to see if he's able to break this down. He's able to metabolize the phenolphthalein. Now, phenolphthalein is your amino acid that's essential to life, and it's found in all types of with protein, foods with protein or protein foods. So these babies, if they're not able to break down this phenolphthalein, it accumulates and it goes to the brain, and it can result in severe mental retardation. Now, this is why every state tests for PKU, because we don't want to send children home with this kind of condition. Now, these babies, they actually look normal at birth.
So, Professor, you're saying that they're tested for PKU via the blood?
Yeah, we do the Guthrie test, Guthrie. It's a blood test, because by the time that this phenolphthalein, it shows up in the urine, brain damage could happen. So that's why it's very important to test this. And that's why we do it quick. We do it with the blood test. But you still have to wait
So I want to get because the slide said it's found in the urine. So that means we don't want it to get to the urine before.
No, that's right. We don't want.
Yeah, okay.
Yeah, because that's why we do a blood test. Because by the time that it accumulates to the point that it shows up in the urine, guys, okay, because it takes longer, that baby is ingesting this protein and he's not able to metabolize the phenolphthalein. And so that accumulates and it affects the brain.
So
And
you're saying
so-
that's already too late when you see it in
Yes,
the urine.
it's-
Okay.
it's- exactly, Danielle. It's already too late by the time that we do the urine test. That's why we do the blood test. And that's why every baby is tested before they go home. Now, we want every baby to be tested because it's so easy to know. And what a crime to not have this test done and have a baby be mentally retarded because we didn't do a test. So that's not good. So we want to go ahead and make sure that we test every baby.
And this is at birth, correct?
Yes, at birth. So what you have to do is we have to wait 24 to 48 hours before we can test it. That's why this test is done. Like, if you're discharging a baby, we take the baby to the nursery and say, okay, mom, we're going to do our PKU test. And, she has to wait and wait. And we do the test. And then we are able to discharge the baby. And then we call mom if it shows up positive. It's called the Godfrey test. Now, these babies do have a musty odor, and they do have some skin conditions that maybe have eczema, and may have failure to thrive. So you're probably asking, well, how's this child going to live? Well, let me go on here. So we have to do some dietary management. So what we're going to do is we're going to put this baby on special formula. All right. So we're going to have the mom what we call maybe special formula such as called Lofenalac. That's Lofenalac.
Could you spell it again?
Huh?
Can you spell that again?
Oh, absolutely. Lofenalac. Now, these are special formulas that are for children who can't tolerate the high proteins. And we have to, you're going to be testing these children from time to time because these children, they do have, they put out a musty odor. That sometimes they may not even grow normally. We'll call failure to thrive with children. They have sometimes a personality disorder, and it's just so hard for sometimes these kids to develop. They also can have delayed development too. So you have to give them a life. They have to just go on a special dietary management. And so they have to be very careful what they eat. Not easy to have a baby with PKU. These are different, kind of sad chapter, really. If you look at this chapter, you have to think of these poor children that it will affect them for the rest of their lives. We also have another problem. It's called the maple syrup urine disease. These are babies that look really healthy at birth, and but the problems will soon develop. So if I'm saying maple syrup, what do you think is a big sign of these children?
More, they can difficult in sucking.
Well, they have like a special odor to them. And you actually is a sweet smelling odor. That's why it's called the maple syrup one. But these children have difficulty feeding. You have loss of the Moro reflex. Remember we talked about that? They have hypotonia, means they have very low tone to them. Irregular respirations and convulsions. These are sick babies. Sick babies. So what you see is that their earwax, their urine, has a very distinct odor to it. It's very like sweet smelling. That's why that's the characteristics of maple syrup. It's this very sweet odor. And how that occurs is caused by ketoacidosis. And then, causes fruity odor of the breath. And again, is confirmed by blood and urine tests. Not easy with these kids. Not easy. The next one I want to hit upon is glycosemia. And what happens is that these kids, the symptoms begin as the newborn is fed. They have a problem with what? With the sugar, the galactose, right? Glucose, right? So they have problems with the sugar. So with these kind of babies, milk and lactose containing products are eliminated. Write that down. So like cow's milk, you could not feed this to that child. You have to eliminate that. Now here, this is what kills me. Breastfeeding must be stopped because again, there's lactose, there's glucose in breast milk, so they can't. So they have to go on like a lactose-free formula or soy protein-based formula. Not easy. So you got to make sure, and that would be a good test question about that cow's milk, okay? So you got to eliminate it from their diet. All right, I'm going to go right into Down syndrome. It's the most common chromosomal abnormality. We talked about this when we talked about mothers who are 35 years and older. Remember the ovums, they get older, and so you have this risk of the Down syndrome where you get the trisomies instead of the chromosomes being nice and paired up. Remember, they get an extra tag onto them. Now these babies, it goes from mild to severe mental retardation, and some physical abnormalities are also seen. And daddies, this happens when the fathers are 55 years and older. We screen for Down syndrome, and we can do that around week 15? Yeah, we do that test. What's that test called? It's called the quad test. Yeah, alpha fetoprotein test. Remember that? Okay, yeah. So we can test for that. But if it comes up positive on the alpha fetoprotein test, we don't make any kind of termination of, what we're going to do with this pregnancy at that time. Write this down. Amniocentesis is the most accurate test to pick up Down syndrome. Amniocentesis is the most accurate. Okay. So here's your Down syndrome baby, and you can see his eyes and his lip and his nose, and even the shape of the head. And they have those simian creases that go straight across on the palm of their hand. And that's how a lot of times you can pick that up in the delivery room, is by that. So these babies, they're kind of limp, and they have kind of sort of like flaccid postures, because again, these babies also have hypotonicity of their muscles. That means they have very low tone to their muscles. And again, they lose their heat, and they're difficult to position and hold because of the low tone of their muscles. They're prone to respiratory illnesses. Yeah, because why? In constipation, again, their muscles have very little tone to them. And I thought this was interesting. Put this in here. There's an instance of acute leukemia is higher. And Alzheimer's disease are more common to those who reach middle adult life. These are all pretty new instances we learned about. And you always have to encourage the parents to what? Express their feelings and concerns. Yeah. We give a lot of support to the parents, and there's a lot of community too referrals that can occur. All right. So we're going to go right into another problem. It's called erythroblastoma fetalis. Now you probably remember this. Remember, we have an Rh negative mom, we have an Rh positive daddy, and they produce an Rh positive fetus. Okay. Remember, we don't like fetal and maternal blood to mix. No, but they can. But we don't like it to. Sometimes small leaks may allow the the fetal blood to enter into mom's circulatory system. Not good. And that causes the mom's body to start producing these great antibodies that cross the placenta, and they can go. I remember like Mrs. Pac-Man, they cross the placenta and they destroy the blood cells of the fetus. That poor little guy is in there, right? And so here comes these antibodies, and they're like Miss Pac-Man. They're going to eat up all this beautiful red blood cells. Well, what happens is that by doing that, that causes the baby to be severely anemic and can have heart failure in the growing fetus. So we can give mom, what can we give mom during pregnancy that will now allow this to happen?
Rogan?
Rogan.
Yeah, Rogan. Yeah. So you remember Rogan. So sure, we don't want this. You don't ever want to have fetal blood and maternal blood kind of mix. They don't, especially when you have this kind of situation with an Rh negative mom. So you give Rogan. Yeah. It's a great
You
place.
still give Rogaine to Rh positive mom and Rh positive infant?
I didn't hear you, Patrick. What was that?
Rh positive mother and Rh positive infant. Do
Yeah,
we still?
if you have an Rh positive mom, you're okay. This is only when mommy's blood is Rh negative. And so you don't know what the baby's blood is, but baby's blood is daddy's blood is positive, you're gonna have a positive baby. So you want to make sure that you protect the babies from being what? From having this happening. Now, this is a pretty serious condition. We talked about this Rogan earlier in the sessions and during, but this is now getting very, very severe anemia, which is called erythroblastoma fetalis. Very severe. And so these babies are needing like maybe a transfusion after being born. Sometimes I'm going to tell you they do a transfusion in utero, and so that gets really, really, really bad too if you have to do that. Moms that are Rh negative, if she has an ectopic or an abortion, she also has to have Haru. Okay, and then you give it during the pregnancy, around 28 weeks, and then she gets it after she delivers, because now you're protecting the next pregnancy. Okay, let's go on here. Let's see. All right, we already did all this. Let's jump down here. Oh, did I ask you what the goal of phototherapy was?
To decrease bilirubin.
Yes, to decrease the bilirubin, the circulating bilirubin. Correct. Okay. So what is the nursing care of an infant who's receiving phototherapy? Well, you're going to have the baby's eyes covered. Write this down. Baby's eyes are covered, right? Got to protect his eyes. He's going to be under the phototherapy. He's going to have to get fluids because the baby excretes the excess amount of bilirubin after the ultraviolet lights are on this baby. Okay, let me go back up here. And so the ultraviolet lights are going to break down the bilirubin. But now we got to excrete it. So how we excrete it is through urine and feces. So we want the baby to be urinating and everything. So we're going to have a little diaper on him. But his skin, as you can see, is what? Is exposed to the bright lights, the ultraviolet light. And you see how beautiful they have his eyes covered here. You're protecting the eyes. Because you could do a lot of what? Brain eye damage with the ultraviolets. Okay. All righty. Well, let's skip down to, I think we're going to go into NAS. This is a pretty important, so heads up on this one, guys. Neonatal absence syndrome. All right, so it's caused by what? Are you there?
Drugs and exposure to drugs.
Yeah, it's caused by fetal exposure to what? Drugs in utero. Mom takes drugs in, right? It crosses the placenta, and therefore the infant is born to a woman who's an addict. So what happens then? If you don't get your drugs, what will happen?
Baby go to fetal distress.
Withdrawal?
Yeah, we'll have actually withdrawals. Just like a person who's trying to beat the addiction, they go through severe withdrawals. So will baby. And so they have a lot, sometimes long-term development problems and neurological defects. Pretty severe. So what are you going to do? So how does the nurse take care of an infant who's withdrawing from opiates? You're going to swaddle this baby. Here it is. So here I put a little diagram on how to swaddle a baby. Okay. And you see how nice and tight he's going to be wrapped up in? And look, see how nice and tight he is here? Yeah. And you really can't do much for these babies when they go through the withdrawal. You got to have them in the NICU, and you're going to be watching them. And they don't like a lot of stimulation. So this is the best way. So write that down. So the question was, how does a nurse take care of an infant who's withdrawing from an opiate? What are you going to say?
Swaddle
Swaddle
the
the baby.
Thank you. Okay. All right. We're going to an infant of a diabetic mom. All right. So you have a large amount of glucose that's transferred to the fetus. So obviously, mom's diabetic, right? And so the baby's living in what? A hyperglycemic environment in utero. So it's like if I was to give you like Snickers bars all day long, all day, every day for 9 months. Oh yeah, gonna be a big baby. And also my little pancreas can't keep up with all that. So when I'm born, what's gonna happen when I'm born? I don't get any more Snickers bar.
become hypoglycemia.
Yes, severe hypoglycemia. So that is always a great test question also, is you're going to always check for hypoglycemia when this baby's born. Because again, he was in a hyperglycemic in utero. But now my sugar has been taken away. All right. So I have a problem, but my fetal pancreas, I'm trying to produce enough insulin, but I can't keep up with it. So my sugar goes down. And they also, because of this hyperinsulinemia it has an excess production of protein and fatty acids, which would result in LGA. What's an LGA? What's LGA stand for?
Big baby.
Large gestational.
That's
Large
just
gestational,
Large
right?
gestational.
Yeah. Okay. All right. So let me see here. So what are you going to test for? You're going to test for hypoglycemia. They usually have low blood glucose levels. And they usually look like a cushion-like appearance. They have have a large face, big head, and they have what am I trying to say? Swollen looking face. Yeah. And then they look pretty healthy. You think, oh, these babies are really fatty and healthy, but they're not. And they also can suffer from RDS, respiratory distress syndrome. Okay, we're almost finished, I think. We're getting too close. And then these babies suffer from hypoglycemia, hypocalcemia, low calcium. And then they have hyperbilirubinemia, which from which they can have jaundice. So does these babies have problems at birth?
Yes.
Yes.
They can have a lot of problems.
Hello.
So they end up looking like this baby. This baby is a sick baby. He has plenty of leads on him. He has an IV here. Here's Patrick. Here's your gavage feeding. Here's a gavage tube right there. This baby is a sick baby. Now this baby was a big baby. You think, oh, this baby's a healthy baby, right? This baby is born to a diabetic mom, and hopefully this baby was taken by cesarean.
Hey.
Yeah. So when you have an infant of a diabetic,
Okay.
you always gotta monitor glucose
Yes.
levels, vital signs.
You want your pills at 7:30?
Oh, okay. Hey, go ahead and mute yourself. If you're talking to somebody, and then you have tremors. You have to watch for signs of hypoglycemia, and again, you got respiratory distress. They're sick babies, and so you have to watch their glucose levels very, very closely. All right. So this is an LGA baby. So what condition of the mom is a contributing factor?
Glucose.
It's too much glucose,
Hi.
right? Diabetic, right? Diabetes. Good. Okay, you got it. You got it. All right. Let's talk about meconium aspiration syndrome. We talked a little bit already about it as a complication. Again, you have respiratory distress. These are babies, guys, that are post-term that had their first bowel movement in utero. Now, it could be a term baby too, so I just shouldn't say just post-term. It could be a term baby that just was under some form of distress, and so therefore he had his first bowel movement in utero. And so you have symptoms, you have respiratory distress, your nasal flaring, these are never good. Retractions, not good. Cyanosis, this baby is blue. He's grunting, he's making noises. He has rales and rhonchi. He aspirated on his meconium, and then he has tachypnea. These babies are sick babies. So they're going to be in the NICU, and there got to be treatment would be keep them warm, oxygen, support care, and of course the NICU, like I said. These babies are sick. So that's why when the baby's head emerges, I'm going to be there suctioning this baby out so that I can get as much meconium up and out of the baby as I can before he takes his first breath. Okay, so here I have some questions. I want to make sure that you know it, but I think we already went over it. We went over acrocyanosis. Everybody good with that? It's normal of blueness of the hands and feet. Everybody good?
Mm-hmm.
So it is normal, and it lasts, I put in here for you, 24 to 48 hours after birth. This is a really good question, guys. So I kind of make sure you know that one. Let's talk about a little bit about the head. I don't think we talked about molding yet. So, molding. We have molding. That's where the head is, this connective tissue it can fold in. It's not set in stone, I would say. It can It can change. That's what I'm trying to say. It can change as the baby comes down mom's pelvis. Thank goodness. Otherwise, a lot of us wouldn't be born. But we have two conditions that I wanted to point out to you. One is called caput succedaneum, and that one is the back of the head. So see, I'm pointing to the back of my head, and back in here, this area right here, okay, is swelling. Don't forget, these are all soft tissue. And so I got some swelling when I came down the pelvis. And so this one, because my suture line is right in the middle, this one crosses the suture line. So you can see that suture line goes down the middle, and you can see where this will cross the suture line. Now, the other one that can happen, maybe she had a forceps delivery, or maybe she had a vacuum assisted delivery, where they put the vacuum on. It can create what we call a cephalohematoma. And I am pointing to the side of my head, you know, and this is where these occur. And it's a collection of blood. And what happens is that, you know, it goes down after a few days after delivery. So all these will go down. You can reassure mom. But this one here, because the location of it, it does not cross a suture line. Does not cross a suture line. So those are always good test questions. And we talked about fontanelles already, so I don't have to go over that with you. But you know about the fontanelles, anterior and posterior. Interior is a diamond shape. The posterior, the back of the head, is more like a crescent back there. All right. We just went over that. Okay. All righty. That looks like we're to the end. I just put in some slides on rounding. Be sure that you read the question. If it says the 10th, you do it to the 10th. If it says to the 100th, you do it to the 100th, okay? And I know some people got this, like if it's about 5, if number is less than 5, what are you gonna do? You round down, you don't round up. If it's 5 or greater, you round up. So these are just little things I put in here, maybe to help you with that, okay? All right, so you can do that on your own in the review. And just remember, you got here, I'm gonna stop sharing now, because congratulations, everybody. We are to the end. Stop sharing. Okay. Oh, here. I was doing all that stuff with hematoma. Okay. Okay, so we went over quite a bit on all these chapters. Anybody have any questions?
We're good.
No? You just got to study it some more?
So yeah, you have the video. We're gonna, so we can use that to study more.
Yeah, I'll post it. Yeah, I'll post the video.
Okay.
I also have another video I can post if this one kind of got messed up with my storm that I was experiencing here. I had to look at that video before I post it. But yeah, I'll do it. Be sure, I hope you wrote down all the ones that I went over and told you to take
Yeah.
notes. Okay, good.
Can you
All right.
also post this PowerPoint?
Yes, I will post it. Where it shows up is Professor P. I give it to her, and what she does, she posts it under announcements, and it'll be like exam 3 reviews, and it'll have all our PowerPoints on there.
There are PowerPoints listed, but for the other teachers that are doing reviews, but your PowerPoint is the only one that's missing.
That's because I'm the last one today.
Oh, okay. All right.
All right, no problem. So I send it to Professor P, and then she'll post it.
Thank you.
Thank you.
Welcome. Okay, remember, just keep studying, and just read the questions. Really, that's why I went over some of those questions the way I did, is so that you could see how sometimes you read into questions too. Don't read into questions.
See you.
Okay. All right, everybody. Thanks a lot for participating.